We are analyzing today how to manage a complex class case, CO2 laser assisted sclerotomy. We're talking about a 72-year-old patient with a diagnosis of pseudoexfoliative glaucoma in both eyes, more advanced in the right eye. He was under a triple combination of brimonidine, dorzolamide, and timolol, plus prostaglandin analog. And under this treatment, he had an unstable IOP. So he underwent to class alone on the right eye on the 2nd of March of this year. We used the technique of subconj mitomycin of 0.2% instead of the using a sponge under the flap. We've been having good results using this subconj injection. So 1 week post-op, honestly, the patient and the surgery looked really good. The IOP was as low as we expected. We usually aim to have 10 or less after the surgery. And the patient felt really, really good, no visual changes. And as you can see, the flap and the bleb look deep. So we were really happy with the results of the first week of the procedure. 7 weeks after the surgery, we see how the changes here are very evident. We can see that the flap is very much more visible. This tells us that the conjunctiva is touching practically everywhere, the whole area of the flap, which also tells us that there's not much flow on that area. He was again under triple combination, and he showed a pressure of 20 millimeters of mercury. We did some images of the flap and of the bleb, where it should be a bleb, and we can see how on the top OCT image, we can see how only on the anterior area, pretty close to the limbus, there is and there are microcystic changes, but we usually like to see it on the whole surface above the flap. We can see how the flap is elevated, so there is flow under the flap, but there is no flow outside the flap. Usually the first step on these cases is to do JAK goniotomy, but we usually perform it in the first days after the surgery. If after the first week of performing the surgery, we don't have a low IOP under 12, we usually perform a JAK goniotomy to increase the flow before the scarring process advances more and makes it more difficult to be effective. But at this stage, we went and did the usual approach after a surgery. So we started by doing a goniotomy. This is a video that shows the technique. It's not the actual JAK that this patient underwent, but it's pretty much what we see. First step is we visualize the trabeculodescendent window where we are going to shoot the laser, and some doctors in the first attempts, when they're not very familiar with the procedure, they have hard time to locate the gonioscope in order to have the two spots that you have to see and then join them together, which is practically the hardest part of this procedure. And after that, we just shoot until we see a defect, and we aim usually to the trabecular meshwork. After we see the defect that we created, we're sure that there is a flow, and then we check the patient. And in this case, we can see in the picture how there is some mild elevation under the conjunctiva above the area of the flap that we created for the clasp procedure. We measured the IOP after the jack goniotomy, and we registered 12 millimeters of mercury, which we were hoping for a lower pressure, but we were happy at that stage with the decrease of the pressure. Now, 2 days after the goniotomy, we asked the patient to come back to be checked again. And we found that the pressure was again high. So we went ahead and performed a needling. Okay, this is the actual procedure on the patient. We go 1.5 millimeters or 2 away from the flap. Okay, in order to have enough space of an area of conjunctiva and tenon that can close itself again after performing the procedure. We are really careful not to make movements that aim to the sclera. We try to keep very parallel to the plane of the sclera. We do as we go and feel the resistance of the tenon, especially in the edges of the scleral flap. And as we can see here, when you break the scarring tissue around the flap, you have an immediate flow with a deepening of the bleb. The problem in this case was that from the 23 millimeters of mercury that we had right before the procedure, it went down to 1 millimeter of mercury. We patched the patient. We applied the ointment of a combination with dexamethasone and tobramycin, and we left the pressure patch for 72 hours. We can see here the changes. This was taken right before the needling procedure, okay? And we can see how there is a shallow anterior chamber right after the procedure. The patient didn't present pain. There was no choroidal changes or detachment, no important visual changes. It was just the low pressure that we had in this case, but it can happen. So we have to be really careful when we do this procedure. The pressure patch after the 72 hours didn't solve the low IOP that we had with this patient. So we proceed with the second stage to resolve this case, which was a viscoelastic injection in the anterior chamber. This we can perform it on the slit lamp. Of course, we have the precautions necessary to avoid any infection. We have to be really careful about that. And the special care that has to be taken into account in this procedure is advancing really slow, because we have a shallow anterior chamber. And in this case, we had a patient that was phakic. So we have to be really careful not to touch either the iris or the lens to not end up having an emergency cataract surgery. So once we identify that the tip of the needle is in the anterior chamber, we slowly inject viscoelastic. Usually do the injection until we have the desired depth of the anterior chamber. We don't inject usually the whole amount of the syringe of viscoelastic. We do it until we see that the anterior chamber is deep enough. Okay. I like to use viscode or a dispersive viscoelastic because it usually raises pressure faster, and we have better results with this approach. After the visco injection, we also do a transseptal betamethasone injection, and this also helps us to control the scarring process that we had active after the needling, and also to help us raise the intraocular pressure. We, of course, leave the patient under antibiotic treatments for 4 days to avoid any infection. We also, this is very important, we leave the patient with a plastic eye shield at night, and we tell them to use it for a week or 10 days to avoid direct pressure of the eye at night, because it has happened before. Some patients move a lot at night, and that can affect very in a very important way the procedure. And we've been having really good results when it's needed to protect the eye, especially at night. What was the final result? Well, this is the bleb after the visco injection. This is around 5 days after the viscoelastic injection of the anterior chamber. We see there's not a very important inflammatory reaction. Okay, we see this diffuse edges of the flap, so this tells us that there is space under the conjunctiva in this area, so there is actual active flow. The pressure was 8 millimeters of mercury under no drops. We can see how the eye looks very quiet, very clear, very white. The patient had no symptoms at all, just a mild blurry vision that it was getting better every day, as he referred. And we can see also again how here we have a deep reservoir, okay, in the bleb, and also here you can see how we have a deeper anterior chamber. We took a OCT again after the whole approach, and now you can see how the cysts are not only at the limbus level, we have them also over the area of the flap, and then this we have this area that is subtenon. This is the flap, which is elevated because we have active flow, okay, but also we have flow to the under the tenon more posteriorly, as we can see here that the image is a transversal image. So we have more posterior flow, which is the desired direction of the flow, and to not leave it only over and under the flap, but more posteriorly. And in that way, we achieved a bleb that is more anatomical and more functional. And we resolved first high pressure after the surgery, and then very low pressure after the surgery. Again, these are complications that can happen. No glaucoma procedure is free of complications, but in this case, and we can have an example of how can it be properly and successfully approached. Thank you very much.